the University of Arizona Bio5 Institute, we bring together hundreds of multifaceted experts that include world-class bioscientists, engineers, physicians, and computational researchers. This team science approach is designed to ignite creative solutions to the many complex biological challenges facing our families and communities, and has resulted in disease prevention strategies, promising new therapies, innovative diagnostics and devices, and improved food sustainability.
Hello and welcome to another episode of Science Talks. My name is Lisa Romero, and this is a conversation hosted by the University of Arizona's Bio5 Institute. Breathing, sleeping, and good health go hand in hand. People with lung diseases and allergies often have problems getting a quality, healthy night's sleep, which in turn can lead to further health challenges. Today, we're joined by a Bio5 member who is a physician scientist who works at the intersection of chronic illness and sleep. Dr. Sairam Parthasarathy is a professor of medicine and clinical translational sciences at the University of Arizona, as well as the College of Medicine's Division Chief of Pulmonary, Allergy, Critical Care, and Sleep Medicine. He's also the medical director of the Banner University Medical Center Tucson Center for Sleep Disorders and director of the U of A Health Sciences Center for Sleep and Circadian Sciences. Dr. Parthasarathy, thank you for joining us today.
Thank you so much for having me. I go by Sai, it's easier.
Okay, I thank you for that. It is easier, and just with your bio alone, I think we're going to need about 3 hours of your time to pick your brain today. But we'll try to keep it to a minimum. We like to just sort of start off by talking a little bit about your work. Your research primarily focuses on the relationship between sleep and inflammation in people who are critically ill and those in the general population, and sort of comparing that. Can you tell us a little bit more about just that general nature of your research and kind of how you got into that area?
Yeah, absolutely. My background was originally in critical care in ICU, and then I transitioned into doing an additional fellowship on sleep after my pulmonary critical care fellowship. And so when I was working with my mentor, wanted to combine those areas. I wanted to look at sleep in critically ill patients, specifically sleep in ICU patients who are on life support mechanical ventilators, essentially, because we know that sleep is important for health. We know sleep is important for the immune system. And so these people who are hospitalized on a ventilator with tubes out of every orifice and in a very uncomfortable and acutely sick situation are highly likely to have their sleep very disturbed and very deranged. And therefore, their immune system can get affected. And we thought that, well, if there's anyone who needs an immune system that needs to fight for them to save their lives, it's someone who's fighting for their lives with an infection in the ICU. And in them, if the sleep is so deranged, that's a problem. So that's why I sort of got into this. That's how I was an ICU physician who got interested in sleep, primarily due to the connection with how disturbed someone's sleep is when they're hospitalized. And but then subsequently, I got so enamored with the brain and how complex of an organ it is. And even though I began as a specialty interest in the lungs, I think the brain is a complex organ, and the interaction between the brain and the lungs in terms of control of breathing and sleep got me very much interested in that area. So that's how I sort of tried to create a new area of research of looking at sleep in ICU critically ill patients. But the connection there is that the way in which it actually worsens, the way in which sleep disturbances worsens the risk for bodily harm and recovery is by affecting the immune system. And so that's why I decided to study inflammation, because it's a easily accessible way of studying the immune system in these people. But of course, now we know that that's hugely relevant in the era of the COVID pandemic and vaccination, of how important the immune system is. And I think the layperson's understanding of the immune system has skyrocketed in these 2 years. So I guess I will see that as a silver lining in all of this.
Yeah, I was going to segue into that because I think we at Bio5, I guess, like you said, it can be seen as a silver lining to something that we would never have wanted a silver lining for. But we have so many of our physicians and our scientists and our engineers that were the work they were doing, the expertise they already had, was ready to pivot to being able to quickly research and translate those into quick solutions and possible solutions, and really look at the epidemic in a different way. And it's been so interesting. As I'm a non-scientist. I've done science communication for a very long time, but it's been so interesting from my viewpoint to be able to see that. And I think that's something really neat at the U of A that we had this, not only the facilities and the resources, but the collaborative expertise. And I know you were and are very heavily involved in sort of making lemonade from lemons in that capacity, if you will. Do you want to talk any more about that and just sort of how that shifted and shaped your work today?
Yeah, I probably could begin by talking about what we were doing with regards to sleep and inflammation in community-dwelling individuals as well as in ICU patients, and then segue into the COVID pandemic. So previously, along with collaborators here at the University of Arizona, specifically the A2DRC, the Asthma and Airway Disease Research Center, Dr. Stefano Guerra, we looked at a biobank samples going back to 1971. People don't realize that, when they talk about the Framingham study about showing the connection between, cardiovascular disease and death, which the Framingham study established. There is a Framingham study of the lung that's here in Tucson, Arizona, which is the TESOUD study, a Tucson epidemiological study of airway obstructive disease, which was established by Benjamin Burrows, who was the founding director of what was then the Arizona Respiratory Center in 1971. And they biobank samples by knocking on doors. Nurses went and knocked on doors and established a sample of individuals and studied them, as well as analyzed their blood samples for markers of inflammation. In both the 1971 as well as in 1983, with a better iteration, sleep questionnaires were administered to them. And so we know how these people slept back in 1971, 1983, and for 12 iterations subsequently, or 12 surveys that were done, all the way up to we know whether they're dead or alive as of the year 2001. And so you're talking, 2011, sorry. So you're talking about a 40-year follow-up from 1971 to 2011, a 40-year follow-up with samples, as well as we know how they slept. In that particular study, we found that people with persistent insomnia, in other words, people had insomnia at one point in time and then 5 years later. In other words, it wasn't insomnia that they transiently had and went away. It was a trait, it stayed there, as opposed to people with intermittent insomnia. Either they had it on the first measurement or the second measurement, but not on both. So they're either remitting or they were incident insomnia. And compared that to control people who never had insomnia at either one of those measurements. And progressively, we found that there was greater levels of inflammation in these people. Not only was there greater levels of inflammation in their plasma, that was banked back in 1971 and subsequently followed up on, but they were also more likely to die of cardiovascular death. So, there's this thinking that inflammation is like the ice pick that actually breaks the ice, and the ice being the atherosclerotic plaques. And so inflammation is responsible for breaking those plaques and causing clot formation in the blood vessels to cause a heart attack. The ice patch is formed by high amount of cholesterol consumption, lack of physical activity, but you need something to break that patch. And for that, you need inflammation. And the inflammation could come from various sources. One of them is inadequate sleep or poor sleep, in this case, insomnia. And so we saw that in this epidemiological study, which has been cited multiple number of times. it was the first study to not only show the increased risk for death, but also show the connection with high levels of inflammation in people with poor sleep, such as insomnia. And so we are doing a deeper dive into that, but of course that took a backseat due to the COVID pandemic. Similarly, in ICU patients, what we decided to do is whether we can do a sleep intervention before the pandemic. Can we improve sleep in these people by using a novel sedative, which acts very differently than sedatives that are used in conventional day-to-day life? And can that help reduce inflammation? And so our preliminary findings before we had the COVID pandemic was that it does indeed do that. In ICU patients who are getting a novel sedative that acts differently than, diazepam or Valium, acts different on different receptors to promote sleep, whether that can reduce inflammation. We showed that it does reduce inflammation. Now, fast forward to the pandemic. We set up the Pulmonary Allergy Critical Care PACS, as we call it, which is our division of Pulmonary Critical Care and Sleep Medicine. We set up a biobank because we were actually at the bedside, and at a time when even research coordinators were disallowed to go into the, this is pre-vaccine, and where we were going into these rooms, taking care of these patients, where we were actually collecting the physicians, all the physicians, the 26 faculty members in the division, were personally collecting the samples and banking it early in the pandemic, back in March, and the first surge and then the second surge. And we saved those samples, not coordinators, because coordinators were disallowed to go into the ICUs because we were on that lockdown situation. And but then they were through phone and through EIRB, with the IRB modification, when the IRB at the U of A was very nimble, allowing us to do electronic consenting and things like that. So we were able to, they were doing that sort of back office electronic consenting, and we were able to collect the blood. And of course, that biobank served as a nidus of growth for research, but not only for the validation of the RT-PCR tests of Ryan Sprisler and colleagues, for allowing people to return back, students to return back to campus. The RT-PCR test validation of what is a true case or controls, positive controls were derived from the biobank, as well as the work of Dr. Yarka Nikolic-Zugic and Aditya Bhattacharya in terms of the COVID pandemic. We were able to give them clearly shown true RT-PCR positive patients were in the ICU at that time. They could serve as a reference population against which they could compare the community dwelling University of Arizona antibody study results. And so, but now what we're able to do is the samples that we collected before in the past, looking at whether sleep promotion can reduce inflammation, whether survivors of ICU, are they having inflammation? And we did another study to see insomnia in people who are released from the hospital. We're able to see the same, to look for biomarkers we're seeing here in the COVID patients against the non-COVID patients who are also in the ICU and also are discharged from the hospital. And that actually served as a very good, fertile research ground for us to try and figure out why people develop long COVID. So we have both COVID positive patients as well as COVID survivors that we've been banking right now in terms of samples and studying them. And we've been able to use the previous studies where the patients are given permission for us to look at various inflammatory markers, both in the ICU as well as upon survivorship from the ICU. And that allowed us to actually make a good effort in getting this $29 million grant, which is looking at long COVID, or the RECOVER study, which is a $1.18 billion investment by the NIH into studying long COVID. And so I think the fact that we were primed in these areas allowed us to really quickly pivot and segue into the COVID research area in order to address burning questions, be it, how long does the antibodies last, or how, what are the reasons why someone develops long COVID whereas someone doesn't? And then we believe we are hot on the trail of something which is premature to be talking about. However, we're coming up with what we think is a unifying hypothesis, because when people develop long COVID, they develop long COVID of the lungs, or long COVID of the heart, or long COVID of the brain, and brain fog and things like that. But we think biologically there's pathways that are responsible for how it ties in these various manifestations of long COVID due to one problem, which is a unifying hypothesis for why that should happen. So it's putting us in a very good situation. And I think, thanks to the establishment of the biobank and the nimble U of A resources, regulatory and otherwise, to allow us to do that, where we're talking to the IRB on a HSPP director on a Sunday saying, the pandemic's here, you're in lockdown, we need an EIRB. And so we're actually sending emails back and forth on a Sunday with our HSPP director who facilitated that, because people are working, as you know, 24/7, 7 days a week, both in administrative side as well as on the research side, because the research side alone can't do it. And even the contract negotiators were actually working weekends and late evenings in order to get some of these contracts for new medications or the Regeneron antibody hammered out, on a weekend. And so I see emails flying back and forth, and I think we went into a pace of work that I've never witnessed or seen before in my life. And I think it's something to be said about team science and teamwork of every member of the institution.
Yeah, it was truly, again, from an outsider's perspective, something to behold. And, everybody was figuring out every day as you went along. And I mean, I want to take a step back further from that and just say thank you, because, I think that, you're a little further out now from those early days with no vaccine, walking into patients' rooms when we didn't even really know what it was or what it could be or what it could cause. And we have so many wonderful physicians, caring, compassionate physicians who truly are, not just say it, but truly are, that are willing to risk their life and put themselves in that position to get data, to get real science, to make decisions based on those things and those things only. And so thank you for being early, an early responder in that capacity, because it didn't, the pandemic has done a lot of harm, but we've saved lives, we've gotten more data, we're further along hopefully for the next time, and that's due to people like you. So thank you for that.
Thank you. I would want to say that my colleagues, did way more ICU time than I did, and I'm very lucky to be part of a wonderful group that really pulled out all stops and was looking out for each other and above and beyond.
Yeah, for sure. I think the other thing that it was a question that I was going to talk to you a little bit about, and you did really touch on this quite a bit, but is that we have this wonderful ability as a research one with a trauma medical center, and that we have these physician scientists like you and who are in there with their research hat on, wondering what could be, what's going to happen, how we can help, but also then you as a physician, a hands-on physician that is seeing some of that research, helping your patients or potentially helping into the future. So, how do you do that? How do you maintain those two hats? And I know there's clear benefits to both, and working together. But that's a tough road. And we've talked to a few other really awesome physician scientists that we have as the members, and they've described it's a tough road. And how does that benefit you in terms of either side of that equation?
Yeah, I know this is sounding kind of tangential, but it's, I think, relevant, to answer your question. Literally this last weekend, I'm a bit of a astrophysics and connoisseur, because I do think that when you start thinking about things like that, you start thinking about meaningfulness and the meaning of existence and things of that nature. So I was having a conversation with my wife, and so trying to define, how and why we exist and what is the purpose. And so
a lighthearted dinner moment.
yes, and because we are empty nesters, and we we have now time to actually have these discussions, and it was about leading a purposeful life, and so coming from that stance, being able to do this, however small scale, the fact that we are put into a position where we can do it, we see that as luck, and we see that as a wonderful opportunity that was given to us, because we know, as physicians, both my wife and I, that there are others who really don't even know about this pathway, are happy doing what they're doing, but we're very happy doing what we're doing. We feel very content and feel like we're leading purposeful lives, and we don't see it as a burden. Because when people say, well, wow, isn't that burdensome? Someone who is a cousin who's in Silicon Valley who does IT work and does 8 to 5 or whatnot. But I don't think they have the job satisfaction that we do when we actually take care of a patient, and the patient says thank you, or we get an idea that we're able to actually implement as a research idea at the bedside. And we see that as being lucky, to being able to do that. So that really takes care of that, and that's a gift and that was given. And so our job is to enjoy it while we are healthy and we can.
Well, I think that makes the rest of us lucky, more so than maybe you, but you're right. I mean, I think you have to find that meaning in doing something as significant as what you both do. Your wife is a physician researcher as well, I know, and thank you. So I would love to have you on again to just talk about sleep, because as somebody who struggles with sleep and has a spouse that has severe challenges with sort of the cycle that you do a lot of work in, which is sort of these pulmonary issues related to sleep, related to heart inflammation, and that it's like the chicken and the egg, as you all know. So we'll have to, I don't want to keep you here for 3 hours like I said, but we'll have to come back to that. But I think what I want to make sure that our listeners, our viewers understand is like you're not only passionate about all the other things you described, but you've actually founded 2 sleep centers here at the University of Arizona at Banner, Sleep Disorders Center and the Sleep and Circadian Sciences Center. And talk a little bit, if you would, just for a minute about what led you to be at the table to kind of say, we need this, I want to lead this, I want to create teams, and maybe just a couple of the milestones that you guys were working on in those areas.
Yeah, the clinical center in Banner obviously takes care of patients with sleep disorders, and it's much needed for the community. And as a land-grant university, as a faculty member of a land-grant university, it's our obligation to make sure that we can serve the needs of the institution. I did want to say that not only do we have a high burden of sleep disorders that needed to be cared for by people who are academics, as opposed to folks who are in private practice who do a great job, but certain complex cases does need to come to us, I believe, so we can offer them novel therapies and other options, as well as some other diagnostic capabilities that we have. The research center is something that came about because we needed a place where we could actually do some high quality research that can actually contribute to the scientific understanding of sleep and circadian rhythms. And we have a great critical mass of sleep and circadian rhythm researchers here at the University of Arizona, but we were handicapped by not having a research center. So many years ago, it's 8 years ago, I lobbied the then Senior Vice President for Health Sciences, saying we really need a place where we can actually study people. And how cool is that if we are planning on a Mars mission? Over here in Earth, we have a 24-hour cycle. We have days and nights, and our body is humming in that rhythm. But when we decide to go to Mars, and we have a moon base camp, and we shoot off to Mars from there, our circadian rhythm of the astronauts or the travelers is going to be shot, because there's no day and night, there's no cycling, there's no immune system cycling along with that to protect the human body, and there's increased risk for cancer because of cosmic radiation and all of that. But NASA is very interested in knowing, studying circadian rhythms for space travel and things like that. And for that, we need a research center. We can have a controlled environment and see what happens to these people when their circadian rhythm is disrupted, because we know that the Nobel Science for Medicine was awarded in 2017. And the cellular machinery, the cellular clocks, ties sleep and circadian rhythms to the immune system has been well elucidated, because it won the 2017 Nobel Prize for circadian rhythms. And every cell in our body has a clock, and it's ticking, and it's maintaining a time. And so that ticking of time is kept entrained by the sun coming and sun setting. But that's going to go awry, and our rhythms are going to go kaput when we are doing space travel. So we need a place where we can do what we call time isolation. We can put them in a place where we can control the rhythm of the day and light and dark. And so we can actually mimic the conditions of a Mars mission, mimic the conditions of the moon station, and see what happens to these human bodies before we actually embark on that and then, fly by the seat of our pants. We can't do that. And so that's some, really cool work. But there's also research showing how, the circadian rhythms can affect day-to-day human body conditions. The lung inflammation of COVID ARDS, what's happening to the cellular clocks? Can that make the lungs drown more easily than not drown? Those are all very interconnected, and we know the cellular machinery, but we need a place where we can do that research. So after 3 years of lobbying, 5 years ago, we were, approved for the establishment of the center, because as with everything, we have to do justification for why we need a resource. But unlike other research where we can do it in a animal facility, or we can do in a petri dish or in a BSL-3 facility, this research, we needed something like the BSL-3 facility. We needed infrastructural support. So we have a research center, which is a 4-bed research center, and soon to be actually an 8-bed research center. And we will be able to not only change the light timing, but also the light frequency, how much of blue light versus red light. We can also change the intensity of the light. You can also change the gases that we inhale in this place. You can actually add a little bit more of CO2 to mimic global warming and see what does global warming do. We're working with Dr. Esther Sternberg, looking at what happens to a slight increase in CO2. What does that do to sleep? And what does that do to your cognition the next day? Our theory is that with more and more global warming, we're going to sleep less well, and actually we're going to be cognitively more impaired during the day. When we talk about global warming for various good reasons, we need to talk about it, but it's also going to affect the brain function better, due to that reason. And we can also administer IV medications to someone in a remote bedroom, as well as draw samples without tiptoeing into their bedroom. And so this is going to be the only sleep research center, and thanks to a grant that we applied for. It's a $5 million construction grant, and it was greenlit by NIH. It's actually only the 3rd construction grant that was received by the University of Arizona in its history. And so, which is actually went to the Sleep Research Center, and we put in a competitive application thanks to a whole lot of teamwork, and that was applied. And 1.5 years worth of drawings and getting NIH to pretty much check every nut and bolt that we're going to put into it, which was approved finally. And the construction has started, and we're hoping that the center will be ready for occupancy in January of 2023, especially with supply chain and everything. We've been conservative in our estimates, but it's going to be one of a kind sleep research center, sleep and circadian rhythm research center, with 8 beds and the capability of doing these time isolation studies where you can isolate the individual from environmental cues of light, of night or day. It's almost like they're living in a cave, but they are lit. It's not like they're dark. but we can mess up their circadian rhythms in a manner in which we can mimic a space travel or other conditions on Earth, like a hospitalized patient. Hospitalized patient has no visual environmental cues because the lights are on all the time, alarms are going off all the time. Again, sort of going back to the ICU situation. So that is how this center came about, and it allows us to do certain things that we cannot do without the infrastructural support that makes us understand the biology of sleep and circadian rhythms, because the circadian rhythms is tied to pretty much everything in the body, be it from brain function, mood, cognition, immune system, A through Z, because every cell in the body has a clock, which is orchestrated by a master clock called the suprachiasmatic nucleus in the center of the brain. So I know I'm getting all, I'm gushing about this because, as you can see, I'm very passionate about that, but there isn't much, there are certain areas, and that's why I think I'm passionate about sleep and circadian sciences, because it's very cross-cutting. Yeah. Altered rhythm with this clock and machinery and whatnot can increase risk for cancer. And that's why women who do shift work are at increased likelihood of developing breast cancer. And that's because the inflammation can be potentiated by these clocks going misaligned. And that inflammation can increase the risk for cancer, carcinogenesis, for cancers arising. So it's sort of cross-cutting. And so that's why it gets very exciting, because you pretty much can connect the dots with anything and everything that you can.
Well, you have every right to be excited about that. That's very cool. I can't wait to hear more about that and see when it comes online. And I think, one of the cool things you said, I think, is and being in an academic medical center is all the applications. And also, we talk about this a lot on this podcast because we have such wonderful people like you who are originally focused in their given area, but now have, as science and medicine progresses, have seen the applications, as you mentioned, for solutions are cross-cutting and can apply to so many different areas. And I tell you what, that is like one of the most interesting things about my job is, I'm like, oh, I'm talking to a cancer doc, and then we start talking about how solutions that they're working on can help other health challenges or other disease states, and just similar to what you were describing. So it's really exciting, and we'll have to have you back once that comes online and you get some cool new projects going with that. I know we're running short on time. I don't want to keep you, but I did want to mention also, because I think I know, I follow you on Twitter, I follow your research and your work, and I know something that's also very important to you, and again, being in an academic medical center environment, is sort of this mentorship role that you have, bringing the junior investigators and residents and doing training, and also this concept of diversity and making sure that we're representative of the people with different backgrounds and different ideas and different cultures as we move forward as scientists and physicians. And I wanted to make sure we mentioned that, because I know that is something you're passionate about and you're involved in formally, and also just, I think, what's in your heart. But I know that you weave that into everything you're doing.
Yeah, it's very satisfying when, I was just saying recently, one of our young faculty members, got a grant that allows him to be considered to transition to independence. And I was just mentioning it to him as well, is that, I'm actually more excited about him getting a grant than a grant that I got around about at the same time. I was like, yeah, but then when he got his grant, I was like, wow, to me, it gave me, as I say, warmed the cockles of my heart, more so than myself getting a grant. And so there's a unique pleasure to lighting the way for someone to being successful that is different than experiencing personal success. And so to me, that's where I draw that energy from. And yes, I'm passionate about UBRs, underrepresented biomedical research. We're part of an R25 Pride training program here, and I believe it's at the 10th cohort now, and which allows people to train in the area of pulmonary and sleep-related breathing disorders. We are soliciting applicants for that, both intramurally and extramurally. It's a summer institute for 2 weeks in summer and in winter each. But there is an opportunity, I think, for being able to tackle disease conditions and find solutions for public good by having a more diverse workforce, because we know that even from clinical care delivery standpoint, people of color find more comfort and are more likely to have better outcomes, better treatment adherence, if they're taken care of by a physician from their race and ethnicity. And so similarly, for research participation, for us to be able to understand what's going on with them, or allow them to be more accepting of getting vaccinated during the COVID pandemic, if they have these messages come from people that they trust, and in that sense, people being represented in our biomedical workforce. And so the more diverse workforce that we have, the more likelihood that it's going to be more participatory by people volunteering to being part of that study. And University of Arizona has just hit it out of the park there, as both HSI as well as Native American, serving institution. And our biomedical workforce, which I was able to have the opportunity to look at it critically, we are, I think, #1 for Native Americans getting their PhDs in the nation. And I believe we are in the top 10 for Hispanics getting their PhDs in this university. And in terms of proportions, we're a robust mid-30 odd percent and great representation in our biomedical workforce, be it at a faculty level or at a staff level. And that's very important for us to understand disease, find solutions, besides the moral, ethical obligation of making sure that we are both diverse and inclusive. It's also important for the advancement of science. And so for someone who's a purist and is looking at it from scientific principles and not all about kumbaya and, those principles, if they really want the answer to scientific questions, it makes good sense for them to have a more diverse workforce. So along those lines, we are very passionate about that, and we spend time on it, not just speak about it. And I'm fortunate to work with a couple of other principal investigators who are passionate about that and learn their passion from them. And that's what's great about this institution is that every time we interact with someone, we learn something great from them, and that allows us to do better. And I couldn't say more than that.
Agree. So I love my job at Bio5, and that I get to see that every day and hear that from our members and from their larger collaborative teams across the university and at other institutions. But I want to say thank you for your mentorship, for your passion and compassion as a physician, and your pursuit of scientific and research that really is meaningful to human beings. Not just great research, but actually makes a difference in people's lives. Very impressive. And I want to thank you for all that you do and that you've done through the pandemic and that you do every day. It's pretty incredible to watch. So thank you for that. And
thank you.
Yeah.
Thanks for the opportunity. Thanks for the opportunity for having me here. Sorry, I didn't mean to interrupt you.
No, that's okay. I wanted to say the same. Thank you so much for joining us today. And thank you to our listeners for joining us on another episode of Science Talks. For more information, please visit our website at bio5.org. And from all of us at the Bio5 Institute, we'll see you in the next episode.
Thanks to our listeners for tuning in to another episode of Science Talks. Continue the conversation with us next time as we learn more about the amazing science happening at the University of Arizona's Bio 5 Institute.